Hello, everybody, and welcome to Hughes Clues Stroke and Acute Intracranial Problems. When we talk about intracranial problems, before we get into the specifics of the specific illness, which this topic is actually stroke, we need to just consider some general principles, and that's that if you have, or inside the head, inside the bony skull, and that's why I kind of have this square drawn, because to me, I think of the skull as this box, and not a soft cardboard box, but a very rigid box. And inside this rigid box of our head, there is the brain, which occupies the majority of the space, and then the CSF and the blood occupy the other two space portions. And because these three substances, the brain, the blood, and the CSF, are encased in this rigid box, then that causes pressure to be inside the head, and of course, rationally enough, this is known as the intracranial pressure. Now, what would happen if to the intracranial pressure if the brain space was increased? In other words, again, you have each of these three items, the brain, the CSF, and the blood, that are encased, and they should be or occupy their specific amount of space. You can see that the majority of the brain space or the head space is taken up by the brain, and then a smaller amount by the blood and CSF. And let's say that something happened and the brain there was swelling within the brain, and so therefore it occupied more space. Well, you would know that that could cause a problem. If you think about your big toe, if you had it encased within a very, very, very tight shoe, and then a semi-tractor trailer rolled over your big toe and it began to swell, you would know that it would begin to feel very uncomfortable because it's jammed inside this tight space to begin with, and now there's more space that the big toe needs to be able to so-called breathe. And if you before you can identify what would happen to the intracranial pressure, you have to realize what the normal intracranial pressure is, and that's between 5 and 15 millimeters of mercury. So if the brain space was taking, or the brain was taking up more space than it's allotted or than it should occupy, then you could see that the intracranial pressure would go up. So what's the big deal with that? Well, first again, we have to understand that all brain cells must have oxygen. And because brain cells must have oxygen and cannot do anaerobic metabolism, if the brain cell is without oxygen for any reason, whether it's because there is no blood flow to the brain from a stroke, or because the individual has had a cardiopulmonary arrest, or because there's a drowning victim, regardless of the problem, if as long or when there is less O2, then the ATP production is decreased by that brain cell. And most of the ATP that every cell produces is used to push out sodium and bring in potassium. That's called the sodium potassium pump. And if there is not enough ATP to keep that mechanism working, to keep that pump working, then sodium will stay in the cell and water will follow, and that causes the cells to swell. Now again, if you go back to our toe scenario, you can think that if your toe were to swell inside that very, very, very tight shoe, then that would mean that there is a reduced ability for the blood vessels to bring in blood and therefore oxygen. And because there is less blood flow that's going to not only the cells that are damaged, but then therefore to nearby cells, then that caused those nearby cells to begin to swell. And of course, I could go on and on with this scenario. In other words, more cell or brain swelling causes more brain swelling, and the bottom line is the ICP goes up. And again, this scenario, I did it very specifically with a problem with low oxygenation states because of ischemia from a brain attack, or because the individual had a cardiopulmonary arrest. It can happen from inflammation, the swelling from inflammation, from trauma, from various and sundry different reasons. And again, because the brain has to have oxygen, and within really 2 to 3 minutes, it's a problem. For sure, within 4 to 6 minutes, the brain is going to have this cellular swelling. The brain is far less tolerant than other organs, such as kidneys or other organs in the body are tolerant. They can do without oxygen. The brain just simply can't. And so what are the mechanisms that can cause brain cells to be without oxygen. And of course, I've kind of alluded to the fact that this topic's about strokes, and there are different kinds of strokes. The difference between thrombotic versus embolic is when the plaque problem either ruptures or it just totally occludes the artery and no blood flow goes distal or downstream to those brain cells. Whereas an embolic stroke just means a clot moved from another area in the body and the result is the same. It completely occludes blood flow and no brain or no blood flow goes to the brain cells downstream. Hemorrhagic stroke, we have a burst in the blood vessels, and not only does this cause a problem with blood flow, you can kind of see visually from this picture that there's less blood that is going downstream, but you also have the problem with blood that's sitting on the brain, on the actual brain cell, and that causes a problem with inflammation, and that will cause swelling and edema. Trauma, drowning, and infections, of course, will create other scenarios that we're not going to address in this particular presentation, but on exam 3 you're going to have intracranial trauma, and so we'll revisit this same material. Now, on a good day, the brain has compensatory mechanisms to ensure survival. In other words, if your brain was doing just fine, you were standing on your head, well, the brain has the ability to what's known as auto-regulate blood flow, and that means that there is a constant blood flow to the brain, and the brain can ensure this by either vasodilating or vasoconstricting. However, the brain has to be working well, so it can't be ill in an illness state or have an illness state affecting its ability to do this, and the mean arterial pressure, the MAP, must be at least between 70 and 150 for this mechanism to work. And if these things are not in place, if the MAP is less than what it should be, or if the brain is having some problems, then there could be an issue, a decrease with cerebral perfusion pressure. So how does the nurse know if cerebral perfusion pressure is adequate? Well, we can actually calculate it. It's a mathematical formula, as in a lot of things in the healthcare profession are based on physics and math. And the CPP, the cerebral perfusion pressure, has to be between 70 and 100, and the formula is MAP minus the ICP. So you can see right here that it is a mathematical formula, and it is dependent on two things, the mean arterial pressure and the intracranial pressure. And just like all organs, there is kind of a threshold to where, oh, if it's a little less than 70, we'll be okay. If it's less than 50, then there's definitely a decreased brain perfusion. And then if it's less than 30, well, you've got a big problem. But I want you to know, because I've just thrown out several different numbers for you, is that anytime you see a CPP less than 70, you, the nurse, need to deal with it. Now, I will also say that some textbooks will tell you 60 over 100, but the course value is 70. So if your calculated CPP, if your calculated cerebral perfusion pressure is less than 70, then you need to fix it. You need to do something about it. We'll talk about that as we go along. Now, just kind of a clinical note that the intracranial pressure is not something that you can measure externally. The individual has to have, by a neurosurgeon, this bolt that is drilled through their skull and then placed in the ventricle, and we're talking ventricles in the brain. And then you need to have this little gizmo that you kind of see on the side of this picture here that will actually measure the intracranial pressure. So what I would say to you as kind of a Hughes Clues must do, for every question that's put forward to you, whether it's a quiz question or exam question, if you have the blood pressure, and if you have the intracranial pressure, you had better calculate a cerebral perfusion pressure, because that will, and you need to do it first, because that's going to tell you which direction or where to go in the question answer choices. So to do that, because maybe perhaps you haven't done a MAP calculation before, we're going to go through it. because when you're in the clinical setting, you know that the blood pressure is taken by some kind of machine, automatic device, and then the map is calculated for you. You don't have to calculate it. Well, you do on critical care tests. You're not going to be given the map. You're likely only going to be given the blood pressure. And so when we look at the formula, we can see that to calculate the map, and you know from statistics that map just, or the word mean, it's a mean arterial pressure. Mean means average. And so this is an average pressure over the whole cardiac cycle. And you know that the cardiac cycle consists of systole and diastole. And therefore, logically, you would think, okay, well, then I'm going to add 120 plus 80 and divide by 2. No, you're going to add 120 plus 80 and then divide by 3. Why is that? Because diastole is mathematically twice as long as systole. In other words, it takes the heart a whole lot more time to fill, because that's what diastole is about. I know we thought about diastole as resting. Don't think resting, think filling. That's the job of the heart during diastole, is to fill with blood so that when the heart is ready electrically to eject blood, there's actually blood in the chamber for it to eject. So the ejection portion of the cardiac program is very quick. It is mathematically twice as long as diastole, and so therefore, to get a mean arterial pressure, we need to add 120 plus 80, which comes to 280, and then divide that by 3. So this individual's mean arterial pressure is 93.33. Yay! That's a great value. It's greater than our course number, which is 70. We want the map to be at least 70. And then we have to go that next step further and identify, well, what's the CPP then? And that's where we take the map, the 93.33, and we subtract the ICP value, which is 15, and we come up with a cerebral perfusion pressure of 78.33. Yay, super, super value. That's a good value. This patient has cerebral perfusion. Now when we look at the blood pressure of 80/40 and the ICP of 15, pause the recording, do your own calculations, and get the value. I'm going to keep going so that there's not dead space on the recording. When we look at the blood pressure, we see that it's 80. The systolic pressure is 80 plus 40/40, so that's 160 divided by 3, and then we subtract the intracranial pressure, and we come up with a CPP of 38.33. So you can see that this is not life-sustaining. Anything less than 50 is considered bad. Anything less than 30, which I realize 38 is not less than 30, is really, really bad, as in the patient is likely brain dead. Moving on to the next value, we have a blood pressure of 120/70. And then we have an intracranial pressure of 35. What kind of cerebral perfusion pressure do we get? Well, we can see that cerebral perfusion pressure is 51.67. Bad. So in other words, what I'm getting at is whether you have a low blood pressure and a normal ICP, the CPP or perfusion to the brain can be bad, or whether you have a normal blood pressure but a very high ICP, the cerebral pressure can be bad. And that makes sense from a logical standpoint because both of those values are needed to create a normal CPP. So either one, which means you're either going to have to fix the blood pressure problem or you're going to have to fix the intracranial pressure problem going forth. Now let's get into some specifics of the content that you need to know for exam 1, and that's the stroke information. So we have a 65-year-old that walked into the emergency department, complained of a headache, slurred speech for the past hour while at work. They deny previous health complaints, admits he rarely sees a doctor. He does not routinely take any medications. You can see the vital signs that I've listed here, and then the cardiac rhythm, because most patients that walk in the emergency department with problems will be placed on the cardiac rhythm. Now I'm going to tell you what the cardiac rhythm is. You're not going to have to identify any on exam 1. That is the thrilling things that you get to do for exam 2. So what could be happening just within the scenarios, and what factors place this patient at risk for some kind of intracranial problem? So what could be happening? Well, you're concerned that blood flow to the brain might be disrupted, causing brain cell. Well, again, two major types of blood flow disruption, and those include a blood clot, which could either be from an embolus or a thrombus, but the bottom line is blood flow is occluded, and whenever there is less than normal oxygen delivery to the cells, that's known as ischemia. Now, the least common problem could be that this individual could have a hemorrhagic stroke. So again, if we think about the signs and symptoms, the signs and symptoms tell us that there's a blood flow oxygen disruption to the brain. And we see that the signs and symptoms kind of indicate that there's some loss of function. And these signs and symptoms and the loss of function are related to the anatomical location of the occlusion. In other words, what brain cells are not getting oxygen. That's what's going to drive the signs and symptoms, not the type of brain attack. You're not going to be able to tell from the signs and symptoms whether this is an ischemic event or a hemorrhagic event. And anytime we have a patient that has certain signs and symptoms, we use the mnemonic FAST. And that stands for FAST. F is facial drooping. A is arm moving. Are they in symmetry? Are they able to hold their arms at length, stretched out, and then not have them drift? Is their speech normal? And then time, which we'll talk about a little bit later. So what factors place this patient at a risk? In other words, what am I getting at? What are the risk factors for an intracranial problem, whether it's a stroke, ischemic event, or a hemorrhagic event? And anybody that increases in age, well, that's going to place them at risk, or a hypertension places them at risk for either of these problems, but also the cardiac rhythm. And if you go back and look at that rhythm, this is known as atrial fibrillation. And recall from pathophysiology that with atrial fibrillation, the atria are not contracting normally. They're just fibrillating or quivering like a bowl full of jello. And because they are quivering like a bowl full of jello, then blood will not flow through it. So in other words, there is blood stasis in the atrium, and that causes thrombi or clots to form. So any individual who has atrial fibrillation is at risk for having some kind of clot forming and therefore having some kind of ischemic brain event. Now, I'm going to do a side note here, not really mentioned in any of the content, but you have to know that, let's say you have a patient that comes into the hospital and they're in a regular rhythm and you see them go into atrial fibrillation. Well, it takes 24, 48, and sometimes as long as 72 hours for clots to form. So clots don't happen immediately. It does take time for clots to form. And so when you're asked, well, what would you do first? Would you give some kind of blood thinner so they don't form clots? Well, hey, chill. You've got time. It's going to take at least 48 hours, sometimes as long as 72 hours for a clot to form. So as far as your nursing prioritization, you have time. But that's not necessarily the case when a patient comes in and they're in atrial fibrillation. If you didn't see it happen, you don't know when it happened. So you have to assume that they've been in it for a while, they've been in atrial fib for a while, and so therefore they have the risk of having a blood clot in that atrium. That's just kind of a extra information that sometimes will help guide you as far as your prioritization strategies, which are always on nursing exams. So you continue to assess or monitor this patient and what additional assessments are needed. So anytime there is any patient that rolls in through the door and we do our assessments, we're going to divide or stretch this out. We're going to say you always use A, B, C, D. And A is considering airway. So assess for swallowing and speech, check for the presence of a gag reflex. And then B is going to be check for breathing patterns, if there's any alterations, if there's oxygenation status. In other words, listen to the lungs, count the respiratory rate, check the O2 sats, give additional oxygen if needed. That's all part of B, breathing. Circulation. Circulation is all about blood pressure, pulse, cap refill. Those kinds of things fall under the circulation heading. Bleeding. Then we look at complete neuro assessment, and that's where we look at a Glasgow Coma scale. We're going to check the pupils. We're going to assess whether the patient is awake or not awake, their level of consciousness, and then we're going to identify facial and extremity weakness. Do they have any numbness or paralysis? And as I've put down here, this is very important. ABC prioritization is always a must always a must. And exam questions are going to ask you in a way that's not necessarily jumping out at you. In other words, the question might say, here's your problem. What is the most immediate action? What is the first action by the nurse? What is the most concerning thing? And those are all code phrases for prioritization and where you need to examine and look for those actions or interventions by the nurse that signify to you, well, this is part of airway action, this is a B action, this is a C action, and this is a D action. And you might say to yourself, well, wait a minute, if I had a patient that came in with an intracranial problem, shouldn't I assess levels of consciousness first? No. It's always A, B, C, and then D, LOC, and pupil. And you might think, well, wait a minute, I am not a ding-dong. I can do two things at once, and I know you can. I can do multiple things. I can assess for airway and breathing and LOC all at the same time, but not on an exam. On the exam, you have to separate each of these actions first and show the examiner that you know that these are the orders that you're going to have to do these things. You're not only going to see these on critical care exams, you're going to see these on exit HESI and on NCLEX. And again, we know that all things in neuro, yes, we want them to have a proper airway. We want them to be able to swallow their saliva. We want them to be able to manage their secretions. We want them to be able to breathe. But you know that if there's altered levels of consciousness, this is a big indicator for intracranial problems. And when we look at assessing neurologic status, we do look at the Glasgow Coma Scale, GCS, Glasgow Coma Scales. And it's kind of sometimes important to identify or remember what the Glasgow Coma Scale is assessing. It is simply assessing eye-opening, verbal, and motor response. And I get some researcher came up with this thing, but truly it is not the best assessment tool, because if you had a patient and that patient was dead, you could give them, or they could score a Glasgow Coma Scale of 3. Because note, if you have an individual that's not living, their eye-opening response, they would get 1 point for it, the fact that they couldn't open their eyes. And they would get 1 point for not being able to have a verbal response or a motor response. So even a pet rock could have a GSC of 3, but notice that the top score is 15. What further diagnostic studies are needed to determine the type of brain attack? And as I alluded to, we have to do a CT scan. That is the primary diagnostic test. It should be obtained within 25 minutes and read within 45 minutes of arrival. So between 0, which is the time of arrival, and 45, this individual should have had a CT exam, and the CT exam will be read. Now, the CT report will differentiate between an ischemic stroke versus a hemorrhagic stroke. And that is important to get that differential diagnosis, because that will dictate what kind of treatment is going to be given to that patient. So let's look at the blood pressure of 210/110. We already identified that hypertension is a risk factor for brain strokes, for brain attacks. And would you expect to quickly reduce this value, or do you think you would administer an oral antihypertensive? And the answer is no. Kind of no, depends. So the goals essentially are to prevent further brain damage. Again, we want to keep that cerebral perfusion pressure in a normal range. And we said that was between 70 and 150. Now, I don't know about you, but 150 is super, super high. Your blood pressure would have to be really high. But I want you to know that the patient has to have a MAP at least 70. So we have to get it up to that value at least. And this is per Dr. Reed. So again, I do a sidebar weasel note, and that is I gave you 25 minutes and 45 minutes on the CT and reading of the CT. These are national stroke standards for stroke centers, for hospitals that are stroke centers. Know that Dr. Reed's criteria could slightly vary. And therefore, you need to go by whatever Dr. Reed says, because Dr. Reed writes the exam. I've tried to give you the information that is a national standard, but it may not be a Dr. Reed thing. So pay attention to Dr. Reed's notes and what those values are, because they are important. Again, we want to maintain a MAP of at least 70, and the reason for that is because without the 70, then there is loss of autoregulation. Now, there can be loss of autoregulation, that is the brain's ability to ensure adequate blood flow just because the patient is having a stroke. So antihypertensive drugs may be given if the MAP is greater than 130 or the systolic pressure is 220. Again, these are national standards. And so this may seem a little bit high to you, but what I want to get to you is that you already know that individuals that have a stroke, have strokes because they have long-term or have had long-standing hypertension. And so we don't really, or the healthcare provider doesn't really want to drop that blood pressure very quickly. We usually use IV medications so that we can have a greater control over the lessening of the blood pressure, but we don't want to drop it from, let's say, 210 down to 120. We don't want to do it. We don't want it that low. And if you say to me, well, what number would you want it to be at? I would say it just totally depends. First of all, it depends on the physician and how they're trained. And then it would depend on whether this is an ischemic stroke or a hemorrhagic stroke. The guide is usually a little bit lower for a hemorrhagic stroke because we don't want a lot of pressure, blood pressure, a high blood pressure, because that does cause further bleeding. But at the same point, again, no matter what kind of stroke, we don't want to just drop it down very, very quickly. And so because those values are wishy-washy and it's always, well, that depends on the physician and so many other things, you are not going to be asked by Dr. Reed what blood pressure should you keep. It's going to depend. You just have to realize, well, you got to check it. And it's very important to at least have a 70 millimeter to ensure that there is cerebral perfusion pressure is adequate. Again, we're going to have this patient NPO because the gag and swallow reflexes, those things come out of the brain stem, and if the brain stem is ischemic, then you may have a loss of these central reflexes. They may not be able to cough, they may not be able to swallow and gag, and so we do not give anything by mouth, any fluids, any pills by mouth. And the assessment of the swallow and gag is going to depend on the facility, a nurse, and then sometimes a speech therapist will determine the patient's ability to have a gag and speech, and swallow, rather, not speech. It's been about 45 minutes since the patient arrived in the emergency department. The CT report indicates there is no blood or hemorrhage. How in the left hemisphere? You can see the vital signs in front of you. What are the results of the CT scan indicate? And what are the anticipated treatments? Well, let's look first about the CT scan. So if there is no blood or hemorrhage in the left hemisphere, that means that the stroke is caused by some kind of ischemic event, such as a thrombus or embolus. If it's a thrombus, it could be from an occlusion from a narrowed cerebral artery as a result of plaque or cholesterol accumulation. So this plaque or thrombus or embolus, either one, any of them, will prevent blood flow, and therefore less oxygen is reaching the brain tissue. And there's a cutesy little saying that time is muscle, and if you think about it, your brain is in itself a muscle. It is the muscle that keeps you going. Keeps the machine working. And so we need to get blood flow restored very, very quickly. And that's where the T comes in. This is the time. We need to have this blood flow restored very quickly. Now, I do want to point out that the CT scan does not identify that there is an ischemic event. An MRI that will be done later can specifically identify more what kind of event it is. The CT scan only says, hey, there's no blood or hemorrhage in the brain. And that means if you've got a patient that comes in with signs and symptoms of a stroke, then that means that that's where the assumption goes. So there is somewhat of an assumption that we move forward with stroke treatment because of the signs and symptoms. And that's why it's very important as a nurse that your assessments be very detailed, because treatment for this patient is going to be based on signs and symptoms. And of course, you're not the only one that's assessing. The physician does too, but oftentimes they do put a lot of weight on your assessments. So now that we've determined that this individual is having an ischemic stroke, Then what are we going to do about the anticipated treatment? Well, if the individual came in with symptoms that occurred less than 3 to 4 to 4.5 hours ago, and they don't have a past medical history of trauma or a heart attack or major or surgery within the last 2 months, again, look in the notes for specific time things, then this individual is a candidate for fibrinolytic therapy, and the drug of choice that is used nationwide is TPA. What does fibrinolytic therapy means? Well, a lytic is something that dissolves, and so TPA is a drug that will eat or dissolve through the clot, and this will allow or restore blood flow to the brain cells. And again, we want those blood flow to be restored while the cells are just have less oxygen than normal. Once there is an infarct, that means death, then we cannot resuscitate those cells. They are dead and gone. So again, this is why assessment is very important. It is very important to identify, well, when did these symptoms start? If an individual says, well, I don't know, my husband, I just found him on the floor. I didn't hear him get up in the middle of the night. So if it's an unknown, we have to assume that it is a longer period of time. It is greater than 4 or 4.5 hours, and so therefore that would stop them from being a candidate from TPA. And several students asked me, well, why not? Why wouldn't we just give it? Because of that infarct. Once the cells are dead, and after that time frame, there is an assumption that those cells are dead, giving TPA then places the risk to the patient and not a benefit. And so therefore, that's why it's not given. So the risks are far greater than the benefits, and that's why we do this. Notice that with TPA, before you give it, we do have to assess the INR, the baseline INR, the PT-PTT, and the platelet count. And then no other antithrombotic therapy such as aspirin or heparin should be given in the next 24 hours. It's important when you look at or know what TPA does, because Dr. Reed will commonly ask questions about drugs. And in a standard question, you're going to be asked, well, how does the nurse know that TPA is a benefit? Or how does the nurse know that there's a risk from TPA? And so you don't just simply answer, well, it eats through. No. Dr. Reed wants you to know why is TPA given for this patient? Because TPA can be given for several different vascular problems. It can be given in heart attacks, it can be given in legs, but the bottom line is we're trying to restore blood flow. So that's what the whole purpose. But because it is a lytic therapy, it eats through clots, well, that means that places the patient at risk for bleeding. And when we say, okay, so you have a patient that's bleeding from their gums or from their IV site or from a needle stick that you did when you drew the blood to assess the INR, would you stop the therapy for those kinds of things? And the answer is no, because we know that if I give TPA, if the nurse gives TPA, that they will have some oozing and bleeding. However, the greatest risk, the major risk of TPA is an intracerebral hemorrhage. Well, how are you going to know unless they're under the CT scanner forevermore? Well, all things neuro, you do want to assess level of consciousness and pupil response, and if there's a change, especially, well, really, if there's any change, well, you need to let the physician know, because again, there has been some instances. I've had students in the past that have had a patient that came in with an ischemic stroke. TPA was administered, and then they suffered from an intracerebral bleed. So we know that it can happen, but we have to be spot on our assessments to identify if it does happen. Because the MAP is 133, the physician has deemed it necessary to give an antihypertensive drug. Labetalol, a beta blocker, may be prescribed. When we look at this slide, you can see that it's very busy. There is usually, either on exam 1 or the final, there is usually a question about, well, tell me if a patient came in with right-sided paralysis and they had speech impairment and they seem to have depression or anxiety, all day long, every day, then what kind or where is the stroke? Where is the likelihood of what part of the brain is being affected? And you can see that that's going to be the left hemisphere as opposed to look at the signs and symptoms on the right hemisphere. Now, during an exam, Dr. Reed will go over this a little bit more. Maybe by the time you hear this, you will have noted. You will get what's known as an exam sheet, and this is some notes that you can place down and take into an exam with you. Now, obviously, you can't put everything down, but this is one of the things that I would put down on my exam sheet because I don't want to memorize this information and keep this in my head. There's so many other things that I'm going to have to keep in my head, but I can put this essentially memorization work down on that exam sheet. That will help give me the confidence that, you know what, if I'm asked that question, I'm going to have the information at my hand. I hope this information has been helpful. I encourage you, once you're done with this entire 3 recording presentation, to do practice questions on the intracerebral, intracranial problems so that you can kind of get a sense or a gauge on how well you learn this material. Email me if you have any questions.